Thank you, Manish. Good morning. Can I just have a show of hands? How many of you are doing MIVS? You can just lift your hands up. Okay, how many would like to switch over to MIVS? Who are not doing, like to switch over? Okay, we do have a number of people who are not doing MIVS as a routine. In this talk, I'll basically cover how it all started and what we did initially and how we are doing it now and how the scope and the horizon of MIVS is expanded.
Exactly.
Nothing to declare as far as financial disclosures. The initial work was the credit for introducing sutureless vitrectomy goes to Eugene D. Juan and his team of workers in the MAD lab, and they were the first ones to develop this sutureless vitrectomy on the platform of 25 gauge with the Bosch & Lomb company, and they came out with the first paper just over a decade ago. And this is how the whole thing started. You can see the Bosch & Lomb Millennium 25 gauge vitrectomy as it was introduced. Here the trocar and the cannula system is being used transconjunctivally. I would like you to pay attention to how it is done at that time. See that the trocar and cannula are introduced vertically straight into the sclera without any attempt at displacing the conjunctiva, and then the vitrectomy is done. And this is the exit technique where the trocar is pulled out, and the hypothesis at that time was that 25 gauge opening is small enough, it should be self-sealing or the vitreous should seal it. Now it's been a decade and it has evolved quite a bit in a decade's time. The incision technique, what you saw just now, is no more being done because now we have understood how the sclerotomies should be made, how they heal, how to make a non-leaking or a self-sealing sclerotomy. And I think here the knowledge of the track and the tunnel technique that the phaco surgeons and the SICS surgeons have used have come of great help. Lot more advancements have taken place in the instrumentation. The first generation MIVS vitrectomy probes were very, very difficult to use because they were very flexible and it was difficult to move the eye. And we have better light sources now, and more importantly the cutter technology and the fluidics have improved very vastly. So there's been a sea of change in all these areas, and that's how now limits of MIVS, which originally did exist, now have disappeared, and MIVS has really become the standard of care. This is the PATS survey which is done every year by the ASRS, and this is the latest survey done last year, the results of which clearly show where the 20 gauge vitrectomy stands versus the sutureless vitrectomy. This is clearly shows that over 90, only 3.7% in the US and 7.2% outside US use 20 gauge vitrectomy. The rest all use either 25 or 23 MIVS gauge. So that means over 90% of surgeons today have switched over to MIVS. This is how we started. The original trocar and the cannulas you can see here, this was a 23 gauge. In fact, we never really took on the 25 gauge system. It was a 23 which we started off with, and the trocar was, as you can see here, trocar and cannula came separately. We had to assemble it, and over a period of years the better trocar cannula systems have been introduced. This is the Edge Plus trocar cannula, which comes as a preloaded set that we use today. Incision is one of the tips that you need to remember is go as obliquely as possible. You need to displace the conjunctiva and go in as obliquely as possible. The cotton bud displace the conjunctiva, if you were careful to observe that, and then you go in obliquely till the junction of the trocar and the cannula, and then you rotate it by 90 degrees. And you see how the cannula, once the trocar is removed, how the cannula changes its direction. It's not introduced directly like what was done originally, and here conjunctiva is displaced, the eye is stabilized, and then the trocar and the cannula is introduced. And now notice here that the trocars that are available are so sharp that you don't really need to fixate the globe to a great extent. That's one of the advantages of the present day very, very good H plus trocar cannulas. Important thing to remember when you begin is to avoid having a chemosis or a lot of anesthetic coming into the subconjunctival space. Here you see that the anesthetic has come into the subconjunctival space and had made the conjunctiva very boggy. And here you may have difficulty in really putting your cannulas. And what we do here is try and push the anesthetic agent or the conjunctiva. You just mechanically displace the anesthetic, and then you are able to get conjunctiva and sclera together, as you can see here, and then we are able to place the incision. So in the first place, if you are giving the block, make sure you don't get a boggy conjunctiva, because that's going to cause problems to you in your placement of cannulas. Now, even when we are opening the conch, let's say this was a patient who had a dislocated IOL, so I had to explant the IOL and put a scleral fixated IOL. So therefore we have opened the conjunctiva for our scleral flaps and etc. So even when we open the conjunctiva, we generally no longer go and use 20 gauge with the pre-placed sutures, and we are now using only the 23 gauge, and that's what this video shows, wherein we are using a 23 gauge platform in open conjunctiva. The incision technique is very similar, and you can see that an oblique incision is placed. Now remember that it is not the conjunctiva that's really going to give you a self-sealing wound. Conjunctiva does help to keep the sclerotomy away from the atmosphere, but it is the construction of your wound, the track that you make, the oblique track that you make, and the intraocular pressure, all those combined would give you the self-sealing sclerotomy. I think Manish is going to show you excellent work that they have done with the OCT on that. Or is it a UBM that you have done? Yes. Now when we want to remove, the technique I use a light pipe, which is a solid instrument, into the sclerotomy site, and then as we pull out the light pipe, a firm pressure is applied on the sclerotomy site, either with a cotton bud, or another instrument I use often is the depressor with a rounded end, and that's again the infusion technique. When the infusion terminal is being pulled out, we don't change over and use the light pipe, we just pull it out as it is. Just to show you another video, the light pipe is already in and the cannula is removed first, and then the light pipe is removed afterwards, and a firm pressure is applied. If you are beginning to do MIVS, it may be a good idea to do a fluid air exchange at the end of your vitrectomy before you exit from the wound, because it's easier to obtain an airtight closure than a watertight closure. And generally leakage from the infusion site is never a problem, because you have not really done a great deal of vitrectomy around this. Now that comes back to the question of how much of vitrectomy do we need to do. Now just notice this here, that when I remove these instruments from these two cannulas, there is a free flow of fluid. That means you have done adequate excision of the vitreous skirt. Now why I am telling this point is that the initial period when the 23 gauge vitrectomy or 25 gauge vitrectomy started, it was thought that the sclerotomies would be plugged by the vitreous and then it would heal, and then that's how the self-sealing nature of the sclerotomies were thought to be. And now we know that that was the reason why so many complications were more in the sutureless vitrectomy, like endophthalmitis and retinal detachment were seen more in the initial series of 25 gauge vitrectomies. But now we know that the end point of vitrectomy in MIVS does not differ from an end point of vitrectomy in 20 gauge. It's the same. You need to do enough excision of the vitreous skirt to avoid any vitreous incarceration into your sclerotomy wounds. Now, initially when we started doing MIVS, we thought it's difficult to inject silicone oil. So I know that for at least 6 months or 1 year, so sometime we used to open the conch and convert one of these gauges into a 20 gauge to introduce or inject silicone oil. But we know that today we have very good viscous fluid injection systems in the machines available today, and that can inject silicone oil even through a 25 gauge cannula. So silicone oil injection now is definitely possible with MIVS. You don't need to switch over or change one of the sclerotomies. And the way I do it is this is a silicone oil injection in an air-filled eye. This is the silicone viscous fluid injector with the silicone being injected at the control of a foot pedal, and I keep the other the air is being introduced into the eye all the time. The air pump is on, and I inject silicone oil and let the air go out. This way the eye doesn't collapse. Now if you clamp the air and then inject silicone oil, the eye tends to collapse, and that's what we don't want to do. So once most of the silicone oil is filled, we close the sclerotomy, we just turn off the air pump, and then we remove one by one, making sure that almost all the air bubble is gone out. We can do PFCL silicone oil exchange also through MIVS. The way I am doing here is the silicone oil is being introduced through the infusion cannula attached to the viscous fluid injector, and through a soft tipped cannula here I am aspirating or passively allowing the PFCL to egress from the eye. So this is a passive exchange of silicone oil which is being injected actively through the silicone fluid pump through the infusion cannula. Now this is one way to do a PFCL oil exchange. Sometimes we do run into problems. Now usually what happens when the pressurized silicone oil is being injected under great pressure is that the tubings tend to give way. And what do we do then? I'll show you another video how we manage that situation. This is one case where we started doing silicone PFCL exchange like what I described. The silicone oil was injected through this infusion line, and then we realized that the tubing had come off, and then we had to change over. And what we did in that particular patient was we put the chandelier through the infusion line and used a syringe directly through the other sclerotomy, and this is what happened. The silicone oil tubing came off, and what we did then was we changed we tried to put the tubing. It will never stay. Don't even try it because it's never going to stay. So what I did was I put a chandelier through that infusion port, and I used a syringe which is directly connected to the viscous fluid injector, and used the soft tip cannula through the other port, and the chandelier gave us enough illumination to do a direct PFCL silicone oil exchange. Now these are some of the things that have come through our use. The chandelier, which allows us to see better and do many more things which we were not able to do. I think Manish is also going to show use of chandelier for various steps, so without needing to repeat the thing. So chandelier comes to the rescue in many situations. Now removal of silicone oil. Today most of our silicone oils are removed through the 23 gauge. The infusion cannula is put in very much the same way, and this is the second cannula to remove the oil which is put in, and then we connect the silicone fluid extractor to this, connect it to the machine. But let me tell you, we can even do this manually using a syringe. Now this is an automated extraction system that's being used, and you can see the bubble slowly gets aspirated. The trick here is to watch out for the last bubble which comes out of the eye. Sometimes it tends to get detached from the inside of the cannula and starts floating around, and that can give you a little bit of tricky problems to remove the last bubble. So as long as you take care and direct your cannula towards that last bubble, you are able to get out. And sometimes I do a partial fluid air exchange. Here what I am doing is the air is being injected through the infusion cannula, and I am using a passive aspiration of the fluid so that just the top half of the eye is filled with air, and this allows us to prevent leakages from these sclerotomies. One my practice I have found is that repeat surgeries when you do on the eye, the chances of getting leakage are higher, and then you're probably better off doing a fluid air exchange in some of these cases. 2010, American Academy published an assessment of the ophthalmic technology. They assessed the available literature on the MIVS, and they did come to the conclusion that it is as safe as 20 gauge vitrectomy and has more advantages of rapid healing and less discomfort. So here is a stamp of the organization saying that this is a technique that has withstood the test of time. Some of the accessories that I use whenever I need to do some membrane dissection in the peripheral area, in the close to the posterior pole, I use some of these prisms, to be able to see better. Now here you can see that area we are seeing better using a contact lens system. So you could use some of these adjuncts. It's not necessary that you need to throw out your ring system. Occasional patient where you need to do a very good membrane dissection, you may need to switch over to your contact lens system with the ring and prisms if required. This is how the chandelier is being put for membrane surgery, for laser, for depression, various steps. The chandelier is of great help. Here we are using it for membrane dissection. I'll show more about this in my talk on PDR. This is a situation where we were trying to laser a peripheral break under PFCL, and because of the small pupil, it was very difficult to get to the break. Now what do we do in this situation? I put a chandelier, and then I used a self-depression to be able to laser the peripheral break that we can visualize much better using your own depression. So these are some of the tips that we can use with chandelier. And lastly, the suturing. I don't shy away from suturing these wounds. How do I suture? I make a small flap, open the conjunctiva, expose the sclerotomy, and put a single 6-0 stitch, as you can see. And the tip I have learned is that make a flap in such a way that it does not need vicryl suturing. So what we have learned from MIVS is that it's the vicryl stitches, especially used for conjunctival closure, that really cause irritation to the eye. So as long as you avoid them, I think you can really have a very clean eye or a very white eye within the next 1 or 2 days after surgery. So should I change to MIVS? I think the reason is obvious here. All of you should change over, because if you want the patient to look like this at the end of 1 week and not like this at the end of 3 weeks. Thank you.